Okay, so we're going to finish up this last section on the central nervous system spinal cord lecture. We're going to talk about ascending pathways, which of course are going to be our sensory pathways. And then we're going to talk about descending pathways just briefly, which are going to be our motor pathways. And then we're going to get on to some of these reflexes. So I have to talk about ascending and descending pathways to get to our reflexes. So when we conduct sensory neurons, when we have sensory neurons that are conducting information up, they usually do it through a chain of up to 3 neurons. And so we kind of label each of these neurons. So the neuron that initially starts it all is going to be the neuron, what we call a first order neuron, that's going to take the impulse from whatever receptor it is, right? The mostly cutaneous receptors in the skin, or a proprioceptor that's telling you where your arm is spatially in comparison to, the rest of your body. So those type of receptors that we're going to have in, again, our somatic receptors are going to take that information from these first order neurons are going to take that information, conduct an impulse from those receptors all the way to the spinal cord or the medulla. And the medulla, remember, is the medulla oblongata. So these are called first order neurons. Okay, it's nice and easy, right? Because they're the first neuron in the pathway, in the sensory pathway. So they're taking information from the receptor to the spinal cord. First order neuron. Second order neuron is going to be your interneuron. And usually these neurons have axons that will extend to the thalamus or the cerebellum. So usually these second order neurons, again, are synapsing with a first order neuron in the spinal cord somewhere, and then taking that information, that impulse, up to some higher area in the brain, either the relay center, the thalamus, or to the cerebellum. Then our third order neuron, which is also going to be an interneuron, is usually going to take information from the second order neuron. So it's synapsing with the second order neuron, and it's going to take the information all the way up to the somatosensory cortex. Okay. So there is no third order neuron in the cerebellum. And so that's why, again, these first order neurons will take kind of the information up to the, spinal cord or medulla, and then they'll synapse with the second order neuron that'll take it all the way to the cerebellum. Okay. But if stuff is going to the somatosensory cortex, then you usually have a third order neuron. Okay. So that's your first order, second order, and third order neuron. Let me show you how this works. So here again, you can see, you might have a touch receptor in your foot. And so that's going to stimulate this first order neuron, and an impulse will be conducted through this first order neuron into the spinal cord. Remember, it's going to go through that dorsal root ganglion because it's, again, a sensory neuron coming in. So, and then it can synapse here in the spinal cord, or it may go on further up in the spinal cord to synapse with a second order neuron. And then that second order neuron, again, is going to be somewhere in this spinal cord or the medulla oblongata. In this case, it's the medulla oblongata. And it's going to synapse with that third order neuron. That second order neuron. This is the second order neuron. And that second order neuron is going to synapse with a third order neuron that's going to be, again, either in the thalamus or higher up in the brain. So again, it's going to take this information all the way now to the primary somatosensory cortex. Okay, so those are here: first order neuron, and then second order neuron, and then third order neuron. Okay, and they're showing you that on this end, and then here on this end, you have a proprioceptor. So remember, the cerebellum is going to be really associated with kind of fine-tuning those motor movements. So it's going to take a lot of sensory in from proprioceptors. And so that proprioceptor is going to synapse with, again, your first order sensory neuron. First order sensory neuron is going to synapse with the second order sensory neuron that'll go all the way to the cerebellum. Okay. So remember, the cerebellum only has the second order sensory neurons. So that's how those kind of first order, second order, and third order sensory neurons that are going to the somatosensory cortex work. And then the first order, second order neurons work for the cerebellum. So not too difficult, right? And now the descending pathways are quite a bit easier. So you usually have two groups, a direct pathway and an indirect pathway. We're mostly going to talk about the direct pathway, which are these pyramidal tracks of motor neurons that we see in the spinal cord. And again, these are going to deliver these efferent impulses. Efferent means motor, right? Motor impulses from the brain, again, to the spinal cord, and then eventually down on out to those motor effectors like skeletal muscles. So again, our descending pathways are going to descend directly without synapsing until the axon reaches the very end of the track in the spinal cord. So that's why we're not going to have these like first order, second order, third order ones, because they're going to descend all the way down. That's why we really have these big pyramidal, when we talked about the pyramidal tracks, they're really going to be mostly motor. And in the spinal cord, these axons synapse with some interneurons sometimes. We'll talk about that in our reflexes, and they'll take these kind of lateral tracks, or sometimes with the ventral horn motor neurons that, again, are going to go directly out to these effectors. So this direct pathway is fast, and it's usually used, again, to kind of with those fine motor movements, those skilled motor movements that we need, okay? So that's your direct pyramidal pathways. So they show you these kind of three descending pathways in the brain, which are kind of going to influence movement. Again, we're not going to really go into a lot of detail on them because they're really pretty basic. Again, you're taking these neurons from the primary motor cortex. Again, all the way down, you can see again, this motor neuron is going to be moving all the way down, and then synapse, oftentimes somewhere lower in the spinal cord, again, with these interneurons that will eventually send out information through that last motor neuron to the effector. Okay, so again, the big thing is that, of course, you have crossover, the decussation in the medulla oblongata for most of your innervation right to your skeletal muscles. So, and that crossover again happens in the medulla oblongata at that decussation point, the decussation of the pyramids. So really that's the big thing to remember with your motor neurons is that you have that decussation of the pyramids. But again, I'm not going to focus a lot on. I want you to know first order neurons, second order neuron, and third order neurons, because we do use those terms eventually in later into 202. So I do want you just to be aware of what a first order, second order, and third order neuron is. At least be able just to recognize what it is. Okay, so let's talk about reflexes. This is where it gets fun. So when we talk about reflexes, here we're going to be talking about the spinal cord being, and that's why I included reflex arcs, even though, again, they include the peripheral nervous system, because the integrating center for your reflex arcs is going to be in the spinal cord, not in the brain. So again, and the integrating center will occur in the gray matter here. Like you can see in this case here, it'll occur in the gray matter of the spinal cord. So a reflex is fast, it's predictable again, it's a very automatic response to some type of change in the environment that you usually are not consciously thinking about. And it's helping us to maintain homeostasis. So for example, you touch a hot object, okay? That sensory information is going to be quickly sent back in through, again, that dorsal root, and will synapse with an interneuron in the spinal cord, in the gray matter of the spinal cord, and then that will synapse directly with a motor neuron that will, in this case, innervate the biceps brachii muscle, causing you to pull your hand away automatically. Again, helping you to maintain homeostasis. Your finger was being burnt. Again, you want to remove it very quickly from that change. So reflexes are pretty interesting because we can actually test different reflexes to test for different dysfunction in different parts of the spinal cord. So that's kind of what we're going to talk about here. So reflexes, again, may be spinal. We do have some reflexes that are cranial and will go through some of the interneurons in the brain. And then somatic or autonomic. Autonomic being again, that portion of your nervous system that has to do with the parasympathetic and sympathetic nervous system. So let's talk about these reflexes. So here's my funny one for you on, lack of reflex there. But a reflex obviously is a really rapid, predictable motor response to a stimulus. If you're an Android, you might not have that proper programming. But reflexes can be intrinsic, which means we're born with that intrinsic reflex. So here's a case where babies, if you press on the bottom of their foot, they will immediately curl their toes around. And then we'll also talk about some of these learned or acquired reflexes. So again, as you get older, you are going to learn how to drive. And so you'll have reflexes that will be associated with driving that will happen very rapidly, but those are learned reflexes. So again, how to avoid an accident. In certain situations, you'll have reflexes associated with that are learned reflexes. Okay, but we have a lot of these intrinsic inborn reflexes as well. They're going to involve only peripheral nerves in the spinal cord. So that's what makes it like a reflex, right? And sometimes there are some reflexes that involve higher brain centers as well, but usually again, your reflexes are only involving peripheral nerves in the spinal cord. And then sometimes from there, that reflex arc will still happen, but then sometimes information will be sent off from the interneurons in the spinal cord to the brain as well, okay, to some of the higher centers as well. But the initial reflex arc will go, again, straight to that effector through the spinal cord. So that's the big thing there. So there are going to be 5 components of a reflex arc. This is pretty easy. There's going to be some type of sensory receptor, right? That's initially going to stimulate an impulse in the sensory neuron. That sensory neuron, of course, is coming through that dorsal or posterior root ganglion. And then when it comes into the spinal cord, it's going to hit the integrating center or an interneuron, right, in that gray matter. And then it's going to synapse with a motor neuron that will go out again then to its effector. Okay, so in this case, it was a skeletal muscle, or it could be a gland or something like that. Okay, so that's your reflex arc. It's called the reflex arc because that's what it basically is. It forms this nice arc. Okay, now a reflex arc is our kind of simplest type of pathways, but some of these reflexes are a little more involved than this nice, easy reflex arc. So we're going to talk about some of these kind of more involved reflex arcs when we get to things like crossed extensor reflex, which is actually pretty cool. So we're going to talk about some of these important spinal reflexes that are used more clinically. And so we'll talk about the stretch reflex, which everybody pretty much knows the stretch reflex because you've all had your, patellar tendon tapped on, throughout your just normal, visits, clinic visits. You've had this done. And then there's a tendon reflex, a flexor withdraw reflex, and then the crossed extensor reflex. So we'll talk about the flexor withdraw reflex and the crossed extensor reflex. They kind of go hand in hand together. So we'll talk about those. So again, spinal reflexes are going to occur without direct involvement of higher brain centers. So the brain can be advised, there might be an interneuron that goes off of this. It'll be advised of the spinal reflex activity, but the integration, the decision, again, of what's to happen with that motor output happens through the spinal cord. And it's not really a decision, again, because this is a reflex arc. It just automatically has that connection once it's stimulated, that sensory neuron stimulated. So testing of some of these somatic reflexes, again, like I said, is going to be important clinically because if that reflex isn't present or isn't present fully, can help us understand that there might be potentially an issue with the central nervous system. So sometimes, again, that reflex might be really exaggerated and kind of over the edge. Sometimes you just have less of that reflex, or that reflex isn't quite properly, performed. So maybe halfway performed, or it's completely absent. And that can, again, let us know what's going on in certain areas of the central nervous system, especially within certain areas of the spinal cord. So most commonly, these reflexes that are assessed in a clinical aspect are the stretch flexor and the superficial reflexes. So we're going to talk about the stretch reflex, the flexor reflex, and the superficial reflexes all here. So stretch and tendon reflexes. These are reflexes that kind of smoothly coordinate our skeletal muscles after receiving like proprioceptor input regarding two things: the length of the muscle. So information will be sent from these receptors called muscle spindles. And that muscle spindle, again, is a type of proprioceptor. And so it will tell us, again, if a muscle is stretched or not. So those muscle spindles are doing that. And then we also have these things called tendon organs, and they will send information on the amount of tension in a muscle. And so obviously, again, the tendons are attaching a muscle to a bone. And so they are kind of our best measurement of how much tension is being put on that muscle through that tendon. So we have little, again, receptors in there called tendon organs that are going to monitor that tension. So this is just showing you, again, these muscle spindle receptors here that you'll see in the muscle that will measure, again, the stretch on a muscle. And then here you have your Golgi tendon organ that, again, is actually going to basically be a receptor for the tension, again, on that muscle. So, and then you can see kind of how these receptors would be stimulated. So in an unstretched muscle, they'll show you action potentials are generated at a really constant rate associated with that sensory fiber. As that muscle is stretched out, the stretching activates this muscle spindle and it increases the rate of action potentials. And so the more that muscle is stretched, the faster the rate of action potentials will be. Okay, so that's how those work. So let's get into this stretch reflex, which is this is the reflex that's the easiest one. I know you all know this reflex. So the way that this reflex works is, again, we're measuring the stretch on mainly the patellar tendon and the quadriceps muscle. So this is the example of what we call the knee jerk reflex. It's a stretch reflex that's innate in us, really to help keep us from our knees kind of buckling when you stand upright. So this is what really helps to keep us standing upright. It's a postural reflex. And so, again, stretch reflexes help us maintain muscle tone, but again, they are also called postural reflexes because they help us maintain our posture while we're standing, okay? And I'll adjust it reflexively. This will make more sense as I kind of show you the image to this. So let's look at, and there's other examples. There's some examples, again, on the spine, but we're really going to talk about this knee jerk reflex because this is the one that you're going to use clinically. So what happens is, when you do this stretch reflex, what we call the patellar reflex, because you're going to be tapping the patellar tendon. Now, remember, this patellar tendon is going to be attached to your quadriceps muscles, which are extensors, right? So tapping this patellar ligament is going to stretch the quadriceps, and when it stretches the quadriceps, right, because you're pushing in on that tendon that's pulling on the muscle, when it stretches the quadriceps, it's going to excite the muscle spindle here, right? And as it excites that muscle spindle, that is going to send the sensory impulse, right? An afferent or sensory impulse back to the spinal cord, where it's going to synapse, one directly with, in one case here, a motor neuron that is going to go to the quadriceps muscle, okay? And so it will directly innervate those quadricep muscles to contract, and that will cause, again, that knee-jerk movement that you get, right? Because those quadricep muscles are extensors. They're extending that lower leg, okay? So again, it's in response to if the quadriceps muscles were stretched, right? That would, then again, that would signify kind of the relaxation when you didn't want to of that muscle. So then it's going to contract to help keep you standing upright. It's just a reflex that we have to help keep us standing upright. So those quadricep muscles will contract, right? Making sure that that leg stays extended to help keep you upright and keep your postural standing, okay? So that's one part of it. Then you also have that same sensory neuron will not only synapse with a motor neuron, but it's also going to synapse here with another interneuron that then will synapse with another motor neuron. But in this case here, when it synapses, it's going to release inhibitory neurotransmitters. And so what that's going to do is it's going to prevent the antagonistic muscles, which are the hamstrings, from contracting to help resist your flexors, right, from contracting. So it's kind of a pretty cool reflex because, again, not only are you directly stimulating the extensor quadricep muscles, but then you're also inhibiting the antagonist hamstring muscles. So that's when you're doing, again, this stretch reflex, the patellar knee-jerk reflex, you are testing this reflex in the L2 to L4 region of the spinal cord. If for some reason there is damage, especially to that the anterior or ventral horn here, then this, or even the posterior horn here as those sensory neurons come in, then you can see that damage in, again, a decreased patellar reflex function. So that's one of the reasons that you test that. That test is kind of your L2 to L4 region. So again, tendon reflex is going to involve polysynaptic reflexes like we saw here. This is polysynaptic, where you have, a neuron, sensory neuron here that's actually innervating more than one neuron, synapsing with more than one neuron. And a lot of times your tendon reflexes will help prevent damage due to excessive stretch. So I'm going to show you this in just a minute. So this will prevent, a muscle from stretching too much. And this is important for, again, kind of smooth onset and then termination of muscle contraction. So I'll show you what this looks like here. So again, here, in this case here, let's say the quadriceps contract really strongly, okay? And so the tendon organs here are going to be activated because as they contract, it's going to put a lot of tension on that tendon. So what will happen then is it'll send sensory information, again, back to the spinal cord. And then these afferent fibers are going to synapse with these interneurons, one inhibitory and one, again, going to stimulate, releasing neurotransmitter that will stimulate a motor neuron. And in this case, now kind of opposite of the last case, in this case, we're actually going to release neurotransmitters to inhibit the quadriceps because, again, it was contracting too strongly in this case. We want to prevent damage to that muscle and that tendon. So it's going to inhibit some of that contraction and then stimulate the antagonist muscle, the hamstrings, to contract, okay? So this is just kind of the opposite case of this one here, and where it's doing this reflex to help prevent overstretching or over contracting that muscle and overstretching the tendon, I should say. Okay. So those are some of the, I probably won't focus on the tendon reflex as much as I'll focus on this one because this is the one that you see clinically. Then let's talk about this cool reflex called the flexor and crossed extensor reflexes. And so first we're going to talk about the flexor withdrawal reflex, and then I'll show you how the crossed extensor reflex comes into play. Because usually if you have the flexor withdrawal reflex, the crossed extensor reflex will also be initiated. So the flexor withdrawal reflex is going to be initiated when you have some type of painful stimulus, okay? This is going to cause a really automatic withdrawal, right, from that. So again, like you touch something hot. And so this is usually ipsilateral, again, on the same side, and polysynaptic because it's just going through the spinal cord, right? So it's ipsilateral because you're not going through the decussation that happens in the medulla oblongata. You're in the spinal cord, so there was no crossing over yet. So it's ipsilateral, but also polysynaptic. There's going to be more than one synapse that occurs, okay? And you'll see there's going to be more than one muscle that comes into play here when we talk about the crossed extensor here. So this is a really protective and important reflex for our survival. The brain can override this. So for example, when you take 202, you are going to have to draw your own blood. You're going to prick your finger, and your finger is going to want to get away, but you can actually hold it down and your brain can override your arm from pulling away. So you do have some override to this if you know it's coming, if you know it's going to happen, right? But let's talk about this flexor withdrawal reflex. So we see this flexor withdrawal reflex in babies. So you can test babies for this. I'm just going to show you what this looks like. So, I'm sure have an ad that's associated with this. So sorry. I always wish I could skip the ads, but there's the downside of using YouTube videos, right? But it's cool to see this reflex.
So the next reflex we're going to test is the flexor withdrawal reflex.
This one has an onset of 28 weeks and an integration of 1 to 2 months. This one also can be irritating to an infant, so if you're going to do this reflex testing, you might want to do it later on. Typically you'd want a pretty rested, calm baby for this, so he might be a little...
So again, this is an innate inborn reflex, and you're going to see again she's doing this withdrawal reflex. She's going to poke the foot with a sharp object here. So this is
hard to visualize because his legs are moving so much. I'm going to use the end of this pin cap and poke the bottom of his foot. And we saw it withdraw, and dorsiflex and his toes extend. I'll see if I can get him to do it again. There you go.
So you can really see that withdrawal reflex. So, and again, this is something that they'll oftentimes test your infant for when you bring them in to make sure that they have this flexor withdrawal reflex. That tells them again that this reflex is intact and everything where it should be in terms of this reflex in the spinal cord. So, and then here you can see, again, this is just showing the same thing, the sensory input coming in. You put your hand on something hot, the sensory input comes in, again, connects with an interneuron, and then also sometimes directly with the motor neuron that goes out to cause, again, the effector to contract. Okay. So now we're going to talk about this flexor reflex, this withdrawal reflex, but I'm going to introduce the crossed extension reflex that oftentimes goes hand in hand with it. Okay, so let's say you're walking along the beach, okay, and you just happen to accidentally step on, you're not really paying attention, you're looking at the beautiful water, and you accidentally step on a piece of glass, okay? So pain receptors in that foot are going to stimulate that sensory neuron that's going to bring information to the spinal cord, and it will synapse with, again, these interneurons here. One of the interneurons will synapse and release stimulatory neurotransmitter, and that will go to, again, the quadriceps muscle causing again, I'm sorry, going down to the, sorry, I got the wrong muscle there. Sorry, going to the extensor muscles, the hamstrings, because we want to pull away, right? So the hamstring muscles will contract here. And as they contract, again, they'll cause flexion, and that'll allow you to pull your foot away. Okay, so sorry about that. So this, again, we have this sensory input coming up here. Again, now synapsing with the inner neuron, and then synapsing with this motor neuron that's going to the hamstrings, and again, causing again that flexion, that contraction and flexion of that lower leg to pull your foot away. Because we want to pull that foot away. Now, what's interesting is you also, again, will have this inner neuron that will synapse with the antagonist muscle here, and it will inhibit the quadricep muscles from contracting here, which would be your extensors, okay? So kind of interesting to see how that happens. So again, this is, that is all the withdrawal reflex. Now, what's cool is that you also have, again, this crossed extension reflex. So as you're going to contract, again, the hamstring muscles and flex this leg, you want to do the opposite, right? Of the other leg, you want to make sure the other leg stays extended so you don't fall over, right? So what's going to happen is it will also synapse here with a motor neuron that will move across this gray commissure. So again, this inner neuron will actually cross over through that anterior gray commissure. And then here, synapse with motor neurons that go to the extensor in the opposite leg. And it will stimulate those muscles to contract, making sure, again, that you keep this opposite leg extended. That's the cross extension reflex. It's kind of cool. And it all happens in the spinal cord, all in one shot. So again, you know, one part of it is the withdrawal reflex, again, going to the hamstrings and again, causing the contraction and the flexion of the leg. And then here again, you know, going to the extensors of the left leg and making sure that that leg stays extended. So kind of cool that it crosses over like that. So again, that's called the crossed extensor reflex. It occurs when, you know, the flexor reflex in the weight-bearing limbs occurs, and then it will do this again to extend the opposite leg and maintain balance. So it consists of, again, the ipsilateral withdrawal reflex that's happening on the same side as the painful, you know, sensation came from, and then the contralateral extensor reflex. So again, just to make sure that you keep that opposite leg extended to keep you, you know, balanced on that opposite leg. So again, example, stepping barefoot on broken glass causes that damaged leg to withdraw and the opposite leg to extend to support that weight shift. Someone, again, may also grab your arm. That causes that arm to flex and the opposite arm to extend to pull the body away. So try some of these reflexes, you know, see if you can get, or if you can do this to a roommate, you know, you can like sneak up and grab their arm. They can't know that it's coming because you have to stimulate that reflex. And remember, they can override that reflex if they know you're coming. But try some of these reflexes out and see, you know, how these reflexes occur. So try some of them out. So again, that's the crossed extensor reflex. There are also superficial reflexes that we like to use clinically, I told you. And so these are elicited by usually gentle cutaneous stimulation, so not like poking, again, your skin. And these are clinically important reflexes because they usually signal problems with our upper motor pathways, or again, some of these upper cord reflex arcs. So we're going to talk about the plantar reflex and then, you know, the Babinski reflex along with this, and then we'll talk about the abdominal reflex. So the plantar reflex in a normal individual should look like this. If you stroke kind of the lateral aspect of the sole of the foot, that's the stimulus, you kind of stroke it, it should cause the foot to curl, okay? And so you should see the foot just like this kind of curl up. Now, that should be, and that's usually, so we usually say the downward flexion of the toes is kind of the more proper way to say that your foot curls. But you can see the toes are going to flex downward. Okay, so that's the typical response. Now, the irregular response in an adult, again, this is normal in infants up to a year because the myelination in the cord isn't complete. So you will see the Babinski reflex in, infants, but once they hit past a year, the Babinski reflex should go away, and then you should see the plantar reflex. But if an adult has damage to the motor cortex or, to one of these corticospinal tracts, this will cause the Babinski reflex. And so what will happen is instead, when the stimulus is used, you stroke the lateral aspect of the sole of the foot. What happens is their hallux, remember that's their big toe, dorsiflexes, and then their smaller toes you can see will fan out there like that. So this is a perfect example of what we call the Babinski reflex. Again, in an individual that's older than 1 year, Babinski reflex is bad. It oftentimes tells us there's damage, usually oftentimes to the motor cortex, sometimes to corticospinal tracts, but oftentimes to motor cortex. So if an individual was in, a traumatic event, that's something that you can test for. Abdominal reflexes will test your T8 through T12 dermatomes. So I'm going to let you watch the YouTube video on this real quick to see. Oh, geez.
Usually bras fit small-chested women like this.
Yeah. Commercial there. Of course, and it's not going to play for me. Let me try one more time. Sorry, I never know what commercials we're going to get, so.
Now test for the abdominal reflex. Lightly draw the end of a pointed but not sharp instrument across the 4 quadrants of the abdomen. You can use an orange stick or the pointed end of the patella hammer. Avoid scratching the patient's skin as the abdomen is a tender area. A normal reaction would be contraction of the abdominal muscles. Remember that the umbilicus is supplied by T10. The area tested above the umbilicus is approximately 2 dermatomes higher, that is T8 and T9, and the area below is 2 dermatomes.
Test, again, certain areas of the abdomen to see if there is, damage to the spinal cord in these different areas. So that's why it's nice to know these dermatomes if you're going to be testing, sensory for neurological conditions. So obviously, you don't have to know those dermatomes, but I just wanted to show you how this abdominal reflex is actually used. I'm going to go ahead and plug back in here. How this abdominal reflex is actually used for damage within these certain dermatomes. And to those certain, again, regions of spinal nerves for the spinal cord. Okay, so those are the reflexes, and those are some of the clinical applications of those reflexes. Really quick, I just wanted to talk about, I don't know that I've talked about this yet, but I know you get into it a little bit in the peripheral nervous system. So I'm going to go ahead and kind of introduce with our nerves. Remember, just like we had with the muscles, we're going to have with the nerves endoneuriums. Instead of endomysium, now it's neurium because, again, these are neurons. So you're going to have endoneuriums, which are going to be surrounding each of the individual nerve fibers. So if you look here, here's the endoneurium that's going to be surrounding the axon. And then, and this is when, again, you're going to have neurons bundled together to form a nerve. So this is where you're going to have connective tissue in between each of the individual axons, helping to hold them together. That's the endoneurium. Then you're going to have, again, these connective tissue that's going to be around these individual fascicles or bundles of neurons that we call fascicles. So that's going to be the perineurium, just like it was a paramycium. And then here you're going to have the epineurium going around the entire nerve. Okay. And so the dura mater actually blends into the epineurium at the, intervertebral foramen, where that nerve is going to be coming in, that intervertebral foramen into the spinal cord. So again, those are super easy because they're just like the muscle. Endoneurium, perineurium, epineurium, right? Don't you love it when that happens? And then this is just showing you the branching that we've already talked about coming into the spinal cord. So you have spinal nerves again that are formed from these dorsal and these ventral roots. They form these spinal nerves here. And then as these spinal nerves come out, they actually can branch, the spinal nerves then can branch into what are called rami. So you can have your dorsal and your ventral ramus. So here's your spinal nerve. And this spinal nerve is going to branch into this ventral or anterior ramus. It's posterior or dorsal ramus. And then you can even have them branch off, have a branch that's for the autonomic nervous system. And this branch we call the rami communicantes or ramus communicantes. That's going to go, and I'll talk more about that when we get to the autonomic nervous system. So this is going to go to ganglions for the sympathetic nervous system. So again, there's the 3 branches. So it's kind of confusing, right? Because it branches as it comes into the spinal cord, then it forms the spinal nerve, and then it branches as it comes out. And so these dorsal rami are typically, going to supply skin and muscles of the back. Okay. Your ventral ramus is usually going to, again, form a plexus and supply kind of your anterior trunk as well as your limbs. And then the meningeal branch, and that's just, again, organizing these nerves into certain areas of the body. And then you also have kind of a meningeal branch that supplies the meninges that's coming off as well. And then we'll talk about the ramus communicantes when we get to the autonomic nervous system. I just mentioned these. Mainly I mention these for the purposes of lab because you will talk about them in lab. All right. So as always, please let me know. I know there's a lot to the spinal cord. Please let me know if you have any questions at all. And as always, I'm going to post some questions to go, review questions to go with this to help you in terms of organizing this for your studying.